Now I'll move on to small incision cataract surgery. SICS is a cost-effective sutureless technique. Although phacoemulsification has now become the standard of care for most of our cataracts, still once in a while we are faced with a situation when SICS becomes our savior. So these situations and indications may vary between different surgeons, but mostly they are either if there's a very hard grade 5 cataract, the patient has bilateral hard cataracts, you want to visually rehabilitate at least one eye, or the patient has a compromised endothelium like in Fuchs endothelial dystrophy, and you know that this is a very hard cataract, the cornea might decompensate if we go ahead with phacoemulsification. Again, when we have these Morgagnian cataracts, hypermature with calcified fibrotic capsule, and it's very difficult to actually achieve a nice round capsulorhexis, then it helps us to know either SICS or ECC in these situations. And it's always good to know one manual surgical technique. So whenever you're in a fix or you are in trouble, you can actually convert to manual technique and go ahead and finish your surgery. Now, there are different ways of handling the nucleus in SICS. So Blumenthal technique is what is commonly practiced. This is a nucleus removal under AC maintainer, typically described with the use of a sheath glide. We can carry out a visco-expression, just put viscoelastic and prolapse the nucleus out, or irrigating wire vectors can be used. Irrigating wire vectors is best avoided as the least endothelium friendly method. So here I'll just talk about the Blumenthal, a modification of that, and the visco-expression. So here again we make a larger rhexis in SICS. It depends on the size of nucleus you're dealing with, but at least 6.5 is necessary because we are going to take the whole nucleus out. So way larger than phacoemulsification. Here I'm making the side port for the anterior chamber maintainer. Then we go ahead and make our tunnel. The tunnel size can be anywhere between 5.5 to 6.5, again depending on the grade of the nucleus. We start 1.5 millimeters behind the limbus. I personally like giving these side cuts because when there's a hard nucleus, it becomes very easy to prolapse it out if we have these side cuts made. And then we enter with the keratome, and we make sure we cut only while entering and not coming out. A hydro procedure is being done at 6 o'clock so that we can prolapse the anterior pole of the nucleus out. And then we put an AC maintainer. I'm using a McPherson's forceps, engaging the nucleus in the tunnel, and then asking my assistant to switch on the ACM port, and then the nucleus comes out. So here I'm not using a sheath glide. We've just used just a simple McPherson's forceps. From the other side, from the other hand, you can actually pull it, and you can use your, the superior rectus suture that you have passed to cause some traction, and the nucleus comes out very easily. Now this is another mature cataract. So here we make a nice round rhexis. It helps to stain it with trypan glue so that you can visualize a little better. The same steps of tunnel construction, and making a good tunnel is very important when we are doing a SICS surgery. We make sure that the incision is self-sealing. So we do hydro again around 6 o'clock. We can even use a Sinski hook, or if we have a chopper, just prolapse the superior pole if it's not coming out after hydro. And here I'm just using viscoelastic and just prolapsing the nucleus out. So this is a technique of visco-expression. This can be done if your nucleus is not very large and your tunnel is a decent good size. So it can just come out simply with visco-expression. Thank you for your